Well, let's get this party started, I think. So, if you haven't done so already, first and last name, and your agency. It's good to see everybody. And Happy New Year. Let's see. All right. So, if we want to spotlight sign language interpreters, for those who needing sign language interpreters, we have spotlighted them. Linda, if you could help me with that, that would be amazing. Um, their names are Daniel and Matt. Please send a direct message to them if you have any issues. And thank you to our interpreters. We have a slide, thank you, but also thank you. I want to say that as well. Um, During this meeting, please speak loudly and clearly. Speak at a moderate pace, and please avoid idioms, jargon, and technical vocabulary. State your name when you start speaking for the interpreters. And in general, just try to avoid the alphabet soup when you're talking about something. Um, to view closed captions and transcript down at the bottom. This is how you turn that on down at the bottom of your toolbar. Um, Choose from showing subtitles, full transcript, or both. You may adjust the size of the captions if you wish. You can also hide subtitles if you do not want to see the text. So, and that's down at the bottom of your toolbar on the screen. And these are some general tips and tricks for Zoom navigation, those of us who may navigate back and forth, just some general reminders. Um, the mute and unmute, showing who's in the meeting, participants, chat. Um, if you are sharing the share screen and enable closed captioning as we talked about on the last slide. And then it looks like this one might be a little bit off if you have reactions, or it might be in a heart for raise your hand, react. It's in the heart. Um, it might have also been an update to the Zoom application. Ah, so again, thank you to the interpreters for being here today and helping us out. And our official start to the ComNet. ComNet for January of 2026. Um, thank you all for being here. So we're going to get started with just a little icebreaker and a little bit of housekeeping. Please list your name, pronouns, and affiliation in the chat so we can kind of keep track of who is here. And then once we get through that, we also have a fun little icebreaker of what was your favorite childhood cartoon? And if you're new, please also include your email so we can include you for future ComNuts. Maddie, you and I would have been friends growing up because Rugrats and peanut butter and apple were my favorite snack as a kid. This is fun. There are a lot of Scooby-Doo fans out here. Jetsons too. I'm loving to see the millennials of of the group with the Rugrats. And Doug. Yes, Doug was a good one. Ooh, Ninja Turtles and Inspector Gadget. Those are good too. Okay. Well, if you haven't yet, I am watching to see what you put in because this is really fun and I'm enjoying this. But to continue on with the meeting, I can talk about cartoons all day, but I don't think that's why we're here. Um, oh, our land acknowledgement for the meeting is usually this script that we have up, and we have done something a little bit different. Over winter break, we met with uh our Office of Tribal Engagement, and we got a homework assignment from them, and it was to do some research on the tribal lands in our area. And I picked one of the lands in my area and did quite a bit of research, and we actually ended up presenting on it in our team meeting. And one of the biggest things that stuck out to me was the authenticity of doing your your land acknowledgement. And w- before I moved to Washington, I had never done a land acknowledgement. I had never even heard of a land acknowledgement. Um, and I, so it was a brand new concept to me. I have continued to do some more learning about how to do a land acknowledgement because it's like being welcomed into somebody's home, from my understanding. And I just really am grateful that I've had that opportunity to learn and to be welcomed into this land and this home, and that I have had this opportunity to learn um from our office. And I am hoping that I can continue to learn as much as I can, because it was a very beneficial experience. Because I even had the opportunity to learn about the treaties, and just there's so much more to learn. And I don't think I could ever encompass it with just a land acknowledgement. So I don't think the script does it justice. And so I won't be reading through it. But I did want to share a little bit about our experience and how we'll be adapting it going forward. So thank you for the hearts. I appreciate it. But um, we'll I will continue to work on my land acknowledgement and hopefully be able to do some justice from it going forward, more justice for it going forward. Um, so we have our agenda for the day. And as you can see, we have our welcome agenda program updates and our breakdown of our day together. I am not somebody who sits well, so I have incorporated mini breaks for us. So I'm sorry or you're welcome. So if you need anything, I can bring us back to our agenda at any point today. And as you know, our beautiful team, um, Monica, our fearless leader, Nikki, our family engagement specialist, Linda, our communications consultant, Kimberly or Kim, our nutrition consultant, and me, our process improvement specialist. And I am sorry I went so quickly for the interpreter. And for this section, I will do the general announcements and then I'll be handing it over to a couple of members of our team. General announcements. Nikki has been on leave, but she'll be returning on February 2nd. So we'll be happy to see her smiling face again. Um, and we're inviting partners to share updates for the inclusion in the community Chiskin Communication Network or minutes. So please complete the short survey to submit announcements and resources you would like to share with the network, with the Chiskin Communication Network updates. Um, and then another announcement is that we have a student who will be working with us over the next few months. Her name is Sahir, and she'll be with us until the end of April. So if you see her around, uh, that is who she is. And we are asking partners to be aware that ComNet is unapproved for the use of AI technology for note-taking purposes. If this technology is required for accommodation, please contact our team and we can work through that accommodation with you. And then I believe this is where I get to hand over to Kim.
Good morning, everybody. I am sure I'm going to sound like a broken record, but just another quick reminder that we have an updated resource for youth who are transitioning through healthcare transition and many other areas around the age of 18. This resource is ready to help prepare youth as early as age 10 to 13, really. So it used to be called tween to teen, and it's been completely gutted. And I worked with the Youth Advisory Council, a few members from there. So, and I worked with Leanne, who provided the family voice. So a lot of great input. And then I also wanted to share if you recall, back in the spring, I worked on a survey to better assess the supports and resources for youth transitioning in our state. And I have pulled together a report, and it can be found on our website at doh.wa.gov/Chiskin. If you look under the information section, you'll be able to find it under data. And then lastly, I just want to share, if you prefer to have a presentation about what we learned through the report, I'm happy to do that. I'm creating a PowerPoint at the moment, and I'm happy to present to your organization, or you can read it at your own leisure. But there will be more to continue. This is preparation for my capstone, which will be happening beginning early or late fall, early winter. So we'll see what comes of it. I'm really excited. And I will pass it to, I don't know who's up next, but next slide.
I think I am up next. I just wanted to share some budget updates for our children and youth with special healthcare needs program because, as you all know, there's lots going on at both the state and federal level. So first, with the state funding update, just a reminder that this is a short legislative session this year. It is, they passed a budget last year, but this year is for any other bills or budget fixes that need to happen. It's a short session scheduled to end on March 12th. And there is a significant budget shortfall even after last year's budget. So looking at about a $2.3 billion budget shortfall. So that's what the legislature will be trying to address this session. The governor released his budget on 12/23, and I will put a link to that in the chat when I'm done talking here. So you can look at what the governor has proposed, but then the legislature will need to pass their own budget for this session. Between last year, even with last year's budget reductions, we did have several reductions in staffing over this past year. We have lost a total of about 12 roles in our office, which is the Office of Family and Community Health Improvement, which houses our maternal child health block grant programs. And that includes one position from our team, which was our children and youth with special healthcare needs, behavioral health, and transition consultant position. So we no longer have that position on our team. And then I will, if you could go to the next slide, just for federal budget updates. Okay, in terms of our federal funding, I should just say that our state funding funds, part of our staff time. It also funds our neurodevelopmental centers and maxillofacial review boards. Our federal funding comes from the Maternal Child Health Block Grant, and that also helps to fund our program staff, but also our local children and youth with special healthcare needs coordinators in our local health jurisdictions, as well as other partners such as our family engagement partners like PAVE and Parent to Parent and Fathers Network, and our workforce development partners at University of Washington. So this year we had the government shutdown at the start of our period, but we did receive a notice of award after that shutdown ended, but it was only for a third of the funding for the year, because these programs were funded basically till the end of this month. So we received a third of our funding, and we will see what happens on the 30th, whether or not there's another government shutdown or not. The federal government needs to pass a budget in order for us to receive any more of our funds for this year. We do have enough funding that we've saved for coverage of staff and our local health jurisdiction partners through the end of February. And while there is enough funding for coverage of staff and local health jurisdiction partners through February, both state and local partners have been impacted by this kind of volatility and uncertainty around funding for these past several months. So that has compromised our ability to complete some of our desired scopes of work, both at the state and local level. So just wanted to give you those updates on those two kind of timely budget items. And then I will turn it back over to Amanda, I think.
Okay. So those are the programmatic updates we have to start out our session. Uh is there anything that um we do have a couple of minutes before the start of our first session. Is there any questions that need to be answered before we proceed? Okay. All right. I I think that our first speaker is here, Katie. Um, if you are here, hey, hi. Um, if you would like to get started, I know it's a couple of minutes earlier than we had planned, but if you would like to get started, that'll allow you a couple extra minutes. I do have your PowerPoint embedded into ours, so I can drive for you if you would like. Um, and if there is anything you need, just let me know, okay?
Sounds good. Great. Um, and I guess you can advance slides if it's obvious, or I'll say next slide if I'm ready. So, um, hi,
Okay.
I'm ready to start when you are. Okay. Hi, I'm Katie Davis. I also go by Catherine, and I'm here to talk about my family's experience learning to solve problems collaboratively and proactively, and in particular in relation to raising one of our children who has had some difficulties at home and at school that relate to behaviors, unexpected and challenging behaviors. Next slide. Um, so what led me here today was that I testified to support House Bill 1795, which came up for an education meeting vote and public testimony or a public meeting. And the bill itself is to reduce, restrain, and eliminate isolation in Washington state schools. That's how it was phrased originally. Some advocates supported reducing the elimination of isolation from the bill and really to reframe it to reduce or to eliminate the construction of new isolation schools. And that's in part because as a compromise to move the legislation forward. There were also some proposed specific restraints that they want to eliminate use of. So that's context for, I'm going to actually share my testimony. So those are the modifications that were proposed the day of the meeting. And I shared my experience as a caregiver. So you'll hear that shortly. I will also share the broader context of what led us to the experience that I share in the testimony. Next slide. This is just a picture I saw that really was timely during COVID. So just this has been my experience, and things get better. So next slide. Oh, I'm sorry. You know what? I was supposed to do my testimony on that slide, so forgive me. Prior slide again. So in 2017, my sweet 8-year-old child started a new school for social emotional special education supports. Their behavior plan included self-directed breaks in a dedicated space The school team worked with us to set up a peace room with supportive items for regulation. 2 years later, in 2019, we received written notice of restraint and isolation as part of OSPI's reporting effort. We later discovered that the peace room had been stripped of content and had been used for involuntary confinement. My precious child has experienced post-traumatic stress and other mental health effects from those incidents. My heart breaks knowing that I failed to protect them and that I even contributed to this harm, and that students still experience these harms. That is why I support this bill with the modifications recommended by others today. Please protect our most vulnerable students as soon as possible. Next slide. So going back in time, when our kids were little, we had agreed upon a love and logic approach to parenting and discipline. I won't go into the details, but it was more of not a democratic style, but really allowed for discussion with our kids and explanation of why expectations were set. We worked at home. This worked for us at home until our youngest was 6. They were what we would have called strong-willed. And we gave choices when we asked them to do things. They often had big feelings when they were told no, despite not giving in. So a lot of times people said, hold the line and that'll go away. And it really didn't for us. They still felt very strongly. They started acting out or, really responding more emphatically to things that we were asking them to do. And we didn't know what to do. We sought out therapy. We were told to ignore the behaviors in the moment and play with them at other times. We were also referred for sensory testing. Next slide. So in preschool, I'll go through kind of some steps in our journey at school. At preschool, they couldn't nap. They were 3 years old, kind of young for the preschool program. But still, the director said that our child was not normal, which was not helpful. It would have been better to refer us for testing. But we switched them to another preschool and they did well. So we're like, oh, well, they're just strong-willed and couldn't nap. Next slide. In kindergarten, they once again had some challenges. They struggled to follow directions. The teacher modified some expectations, allowing them to have fewer steps to meet, staying on green or whatever the sticker chart was. Sometimes they hid under the teacher's desk. We didn't really understand why. And they started lunchtime play therapy with a trainee from the University of Washington with some success. It seemed to help. And at the end of the therapy, the therapist recommended that we continue therapy. They referred us to their group. But they didn't refer us for testing, and they gave us a list of references on discipline and parenting. And I had, by that point, read all those books, and they weren't working. And so this really turned us off again, where there were missed opportunities to refer for testing and really to talk to us collaboratively about these options. Next slide. In first and second grades, they started to have even more escalated behaviors at the end of the school year and during summer camps. This coincided with the challenges at home that I mentioned before. So we were in therapy over the summer. That was when we were told to ignore behaviors. They were suspended at the start of second grade after pulling the teacher's scarf when they were ignored. So clearly ignoring was not working at school either. And at that time, we had been referred for the sensory testing. And again, yeah, ignoring attention-seeking behaviors wasn't working. Next slide. So I'm going to go a little more into the crisis that we were in. Next slide. These intense behaviors really led to a cycle of crisis. Again, they intensified after that second grade suspension. They were diagnosed with autism and anxiety at the time. There was more going on, but we didn't realize that then. Their behaviors caused us to receive calls regularly to pick them up from school. They were waitlisted for therapies, occupational therapy and ABA in particular. And my work was especially stressful. I had a new leadership role with a group, a new group, and I immediately had to reduce my time to 50% in order to support my child with all these calls to come home. And I was asked to leave after 9 months of trying to get them help. Next slide. So after about 3 months of into this process, after we got after the suspension, we were approved for an IEP. So they started special education. In the meantime, we had switched them to a half day of school. And even after they started special ed, the school didn't have the supports that we needed. So we asked if our private insurance covered ABA technician could help at the school in the afternoons, and they did allow that. It was mostly helpful, but as respite care for me, so that meant I could do a little more work in that time period. They switched schools in third grade for a higher level of support. There was the case manager and the principal were cooperative. We had fewer calls home. It was a big relief, and I thought things were going great. They had occupational therapy in school and support for learning, which were both also critical. And at the same time, as part of the behavior intervention plan, we implemented that peace room that I mentioned earlier for self-regulation breaks. Next slide. So I'll move on to middle school. Next slide. In the first case manager in middle school, and this was coming out of the pandemic restrictions, we set up a semi-private break space, which differed from the peace room in the second elementary school. And that was in what's called the access room. So there's, I think it's now called extended resource, but it's a pull-out classroom for, in our case, for social emotional learning. And that the case manager also supported with problem solving and taking breaks as needed. However, this case manager was abruptly suspended. And then our child had nowhere to take breaks with supervision. The principal and the new case manager proposed that they look for the available person from a list of 3 people when they needed to take a break. And really, to be honest, when they were at that point, they didn't want to talk to anybody. So trying to figure out how to do that just didn't work at all. I wound up taking leave from my new job by that time, so that I could be in the building to support them. And they had increased behaviors that had been extinguished before. So again, they were starting to have those concerning responses to this stress. We considered a new peace room because there wasn't anywhere that the principal felt was a safe place for them. And ultimately, we withdrew them from public school in 8th grade. Next slide. around this time, we realized that our child presented with something called pathological demand avoidance. It is not a recognized diagnosis in the statistical manual of the DSM. But it is in some countries, at least in the United States, we don't recognize it, but it really resonated with us. What happens is that they have a fight or flight response to what they perceive as demands. And our child has expressed it as, they know that they're being manipulated and they don't like it, or they feel that they are. They may want the reward. So if you're doing kind of ABA style or applied behavior analysis types of things, they wind up feeling conflicted. They want it, but they resist because they don't want to be manipulated, and they just are responding to that demand. And that inner conflict actually adds to stress and increases unwanted behaviors. So there, in others, when you're talking to them, they are motivated to do well and to help people. And when they were little, even before I knew about this characteristic of theirs, I would sometimes ask them to help mommy by doing something. So instead of saying, you need to do this, I would say, I'd like you to do this, and this is why. And an example is that when they were 5 years old, they decided they didn't need to hold my hand anymore when they crossed the street, right? Their brother didn't do it, they were, who was a couple years older. And so they just refused. And I said, you know what? I feel scared when we're crossing the street and it's a busy street, and I holding my hand helps me to feel better. And that worked better than punishments or rewards or saying because I said so. I also taught them the phrase, I don't want to, but I will. And that helped. It's like they were heard. They would do things sometimes, but they wanted to be heard. Next slide. So now I'm going to talk about the approach that we've taken. In addition to, we still apply the love and logic idea, but we have tools from a program called Collaborative and Proactive Solutions. Next slide. So as we were transitioning to high school, we discovered Collaborative and Proactive Solutions through a Seattle special education parent teachers student association. They had Ross Green come and talk to us. Ross Green is an author of several books, and he started this program. They discussed restraint isolation, and we talked with our then 8th grader about it. That was when we learned how the peace room had been used in elementary school. So even though I had gotten that notice before of restraint and isolation, I just thought it was, procedural that they took our child to the peace room. But instead, I found out that they had been forced to stay in there. So that was pretty shocking to me. And we also learned that the collaborative and proactive solutions approach is one alternative to restraint and isolation. We involve them in their choice of public school, moving from the 1 year in private school in 8th grade, which actually wasn't a very good fit either. The school that they chose, Middle College, had fewer students. It's a calmer environment, and so the busyness of going between classes really would be alleviated, and it was suited to their goals. So our child wants to go to college, and they felt that having that extra support that this program at Middle College helps students navigate Running Start in Seattle. Next slide. The first month went well in the new school. It was a great fit. However, they started having difficulty with math class. They started leaving the class, and sometimes they were disruptive when they left class because they were responding to something we didn't understand. Math was one of their favorite subjects. So because I had heard about collaborative and proactive solutions, I followed up and got, I was like, I don't think I can do this on my own. So I found this is my abbreviation for CPS is CAPS, or I call it CAPS. And we had a coach who, and we also involved all the other people who were directly related to this incident in math or what was happening in math. So the principal, the case manager, and the teacher for the class. And in fact, I wasn't involved in one of the discussions because I'm not at school and I don't know. So our child was shared with us that math was not being taught like science. And there were lots of word problems and activities. It was not as expected. And they felt unnecessarily harder for them than if it had been taught as a traditional math class. And the teacher, for whatever reason, wasn't able to work with us work with our child on modifying the curriculum to make that math class more accessible for them. So we opted to drop the class with the cooperation of the principal and the special education case manager, and we came up with a plan to complete it later. We also worked with the schools. I guess they have a counselor who helps with planning. Next slide. Oh, what I didn't share on the prior slide was that this extinguished their behaviors. Once we solved that problem, they did well, and they did well in their classes. And now they're in running start. They're taking pre-calculus. It worked for us. So here are some of the concepts of collaborative and proactive solutions. The main idea or lens shift is that kids do well when they can. A lot of times when children are acting in ways that are honestly scary and feel as though they are being defiant, that is interpreted as that they are choosing not to do well. They're choosing to act in this way. When in reality, it is a fight or flight response, and they're not doing well because they're struggling with something. So challenging behaviors reflect developing skills and unsolved problems. And this happens for us also in the medical setting. So just if you see a kid acting out, there's probably something going on for them. Solving problems collaboratively reduces or eliminates the challenging behaviors in many cases. I assume, as with anything, there may be some exceptions, but I've seen this in our own life, and I've actually heard many stories where it's been effective. It also made intuitive sense to me. It aligned with the original Love and Logic discipline plan that we had. And, as we had seen before, their behavior was context dependent. When we switched preschools, they did better, right? When we got them some extra support in kindergarten with understanding the rules, I guess with the lunchtime playtime, they did better. So, one thing we learned was that it may require compromises by adults and children. So in our case, the math teacher in high school in ninth grade was not able to compromise. And, that's acceptable. She had a class full of kids and maybe it wasn't feasible. And we could have advocated for, some other supports that year, but really working with our child, they felt it was best at that time to just not take the class. So And I can also give an example at home. I've compromised, for instance, by, not having meetings that start at 8 a.m. because if we need to get out of the house for me to get to a meeting, I'm a lot less able to self-regulate than if I don't have a meeting at that time. And sometimes I need accommodations, and I have to say to my spouse, um, I don't have to, but I negotiate with my spouse, can you take them on this day because I have a meeting? Because, that way we all stay regulated. So, yeah, next slide. So today we continue to solve problems collaboratively. As I mentioned earlier, our teen is attending community college and Running Start. This year, even they dropped a class when the course load was too much for them. And they're in the process of applying to four-year universities with inclusion programs. So their pace is a little different. But, in some ways they're taking college classes, right? So they're a little bit ahead. But then when they compare themselves to peers who are in Running Start with them, they feel behind. So, it's just understanding that everybody's path doesn't have to be the same and that we can find a way that supports them and our family. Next slide. So my ask for you today is to learn more about collaborative and proactive solutions. There's a website, Lives in the Balance, and also the Collaborative and Proactive Solutions CPS Connection. Those both have resources. You can refer these for patients and families you're working with, or providers who work with kids who have challenging behaviors. And really just shift your lens. Don't blame the parents. Don't blame the kids, and just blame the unsolved problems, because really that's, most often what's causing the behaviors. Thank you so much. And if you're interested, you can also contact your legislators about House Bill 1795. So, thank you so much. And I'm happy to answer questions if anybody has one. Oh, and actually, looks like Kristen had a really good point. We do come from a position of privilege. We have a two-parent home, and we're willing and able to shift our perspective. So, yes, our child is fortunate, and we are as well. Thank you.
I want to share something.
Okay.
So thank you for this presentation. Is touching my heart. So I have a kid with disability as well. He's adult. He's 22 years old, but I'm working at the organization who provide support to family who has loved one with intellectual and developmental disabilities. So I feel you because we have a lot of families. We support families. We have more than 28 languages. So we have a lot of case managers who are being going through this with family in the education, special education system. So school system is it's a little broke down. So I don't want to say they are not good, but I feel that they don't have the capacity. They don't have the yeah, there are too many kiddos. Maybe the teachers they are not qualified to qualify for the special education world. They don't understand. It's hard for them. And then so down the world, our families, immigrant families, so they are suffering as you. I feel when you feel to cry and like a frustration, pain, everything. Mostly on my country, so I'm from Mexico, and disability is a taboo. So our kiddos with disability are hiding, so they don't have any opportunity out there. So now here, so the kiddos they can have a like an independent life. Yeah, if we're guided them through the years. But yeah, the school system is they need more to be more put more attention on disabilities because it's a really tough time for for families. So thank you for sharing that. I appreciate it.
Yeah, thank you. I think Amanda, you can stop sharing the slides if you'd like, and then yeah, or leave it on this one. Yeah. I think Elizabeth has a question or comment.
Oh,
And thank you, Raquel,
I
too. Mhm.
I had a question. Thank you so much, by the way. This is so interesting. I was curious. I feel like PDA is more recently kind of talked about, and I've learned more about it. Um, and I have a 5-year-old grandson who I'm pretty sure also has PDA. And I was wondering what how that diagnosis sort of came about and how it was perceived by the school or the professionals that you work with. I was kind of told the schools are really good at providing, quiet areas in the classroom, and I could see it, and there was, all these comfort items and headphones and all of that. But I was curious about the PDA work and how things could be incorporated into an IEP or 504 plan. How did that work for you? I'm sure it was hard.
Yeah, thank you for asking. It coincided with our collaborative and proactive solutions discovery, right? So
Hmm.
what we wound up doing, and I read a lot about PDA, and it was a self-diagnosis. So our teen and I really were like, we read things and watched things, and I'm a researcher, so I'm a biostatistician. So I read articles, not just TikTok. Um, and so we mentioned it to them, and we are fortunate because my child didn't have an ODD diagnosis, although that's what the school had been saying when they were in second grade. Oppositional
Mm-hmm.
defiant disorder is commonly one that our kids, with challenging behaviors, that's a
Hmm.
go-to.
Hmm.
And really, but our latest case manager has been very receptive to talking about pathological demand avoidance. But really, when we worked with the principal and we were trying to work with the teacher and on collaborative and proactive solutions, we did talk about pathological demand avoidance in that context. But I think, and really talking about using declarative language and providing reasoning for things, and they've been
Hmm.
receptive. So, and we've been really fortunate that their school is receptive. And they did a couple hours of training on collaborative and proactive solutions with the coach we were working with through
Oh,
yeah. So
I
that
wonder if that's available for through the ESDs.
it's OSPI has training through for collaborative and proactive solutions as well. So I provided that
Oh,
too. But yeah,
okay.
look up on OSPI for um yeah, for those training modules.
Okay.
I think you can earn time for that and everything.
Hmm.
Um,
Hmm. One last question. I had
okay.
written down livesinthebalance.org and then the CAPS in schools. Is there any book that you read that's really helpful? Um, I attended a webinar training and I brought home the handouts to my husband and he said, I don't understand what this is trying to tell me. And so I was wondering about a book you could recommend or website with handouts, or is there anything that was really super helpful to you that you remember? I mean, you've read
With
so
respect
much.
with
To,
respect to pathological demand avoidance,
yeah,
can I get back to you? I guess I could send
sure.
resources to Amanda and or I don't know if you want to put your email in the
Hmm.
chat. I can note
Sure.
them. It looks like we have some questions in the chat as well. I don't know if we have time, since it's at 10 o'clock. But
We were gonna go into a break for a
okay.
couple of minutes, but if we want to use some of the break time to answer any of the questions, that is fine with me. If you're okay with it, Katie, I know I asked, the ask was 4 until 10, so I don't want to take any more of your time up.
I'm okay with a couple minutes. So
Okay.
I don't know, or I don't know if those who ask questions, I could just put the responses in the chat in case they want to take a break. So I'm open to either. I don't know, Kristen, Gail, and Nicole. Oh, Nicole's hopping off, but yeah, thank you. And yeah, so I guess if either Kristen or Gail wants to come off mute or just let me know with a thumbs up whether you'd prefer. I guess a thumbs up would be um, if you prefer for me to respond in the chat or continue speaking. I don't know, another emoji besides the thumbs up. Or you can just respond to me in the chat directly. But if I don't hear from you, I'll just do the chat, I guess. Okay. So Kristen, I'll respond directly since you're hanging out, and then Gail, I'll respond in the chat. So that's really helpful. Kristen asked what the PCP recommended back in preschool when our child couldn't nap. And I don't know if we even thought to ask the primary care provider. It kind of happened suddenly. So I didn't schedule an appointment to talk to our provider about the fact that our kid couldn't, wasn't taking a nap or was having a hard time. Really, they were transitioning away from nap at home sometimes, but they behaved fine at home when they didn't nap. So yeah, we didn't think to go to the primary care provider. But yeah, that's a good question.
It just seemed like, I know you mentioned there were missed opportunities for testing.
Oh,
And so I
right.
was just curious, like during those times, did the PCP ever have any thoughts, or were you able to bring it to their attention, or just relying on the school's kind of feedback?
Yeah, I mean, to be honest, I like our PCP. The clinic we go to provides a whole list of the things, milestones and everything. And nothing really stood out then as, autistic. They just, yeah, they're
Yeah.
yeah, and they were three, so it was like carryover from the twos.
Sure. Yeah.
Yeah,
Okay. Yeah. Thank you.
you're welcome. Yeah, I mean, I question that too. Like, how could we have caught this sooner? And yeah.
Yeah. And I think that's evolved over the years, right? Because that's been, I don't know how long ago that was, 10 years ago,
Mhm.
10 plus years ago. So yeah.
Yeah, that's true.
Early intervention has increased since then. So
Yeah, yeah, and who knows if they'd gotten help sooner, maybe the stress response with the PDA, might have been different. Who
who
knows?
knows? Yeah.
Yeah.
Yeah. Thank you.
You're welcome. Jan, do you have a question? And then I'm gonna hop off in a couple minutes.
Yeah. Thank you, Katie, for your story. It was really enlightening, and a story that is probably many families have struggled through. And so when you are working with a family who has Medicaid, they need that diagnosis to get some of these therapies. And you had mentioned that you were self-diagnosed and didn't go
No,
to
just PDA. Just the pathological demand avoidance was self-diagnosed, but the autism, now they have autism, ADHD, Tourette's, all of it's diagnosed.
Okay. Because that's what, you have to get that to get the therapies. Some, if you have private insurance, you can pay for it out of pocket, but okay.
Yeah.
So you did get that. Okay.
Yeah.
Thank you.
Yeah. And I should mention on the Lives in the Balance website, there are licensed mental health providers who are also trained in collaborative and proactive solutions. So I didn't realize that when we got our coach, they were more of an education kind of coach, and we'd use private pay. But I found out that some CAPS CPS providers will provide super bills for reimbursements for insurance, and then they have their licensed therapist. All right. Well, thank you, everybody. It was yeah, I'm thankful to have the opportunity to share my experience, and I hope more of us will be compassionate towards our uh, kids and families who, you know, have these experiences because, yeah, the
Thank you.
judgment is real. Anyway,
Thank you so much, Katie, for coming and speaking with us. I greatly appreciate it. And I look forward to seeing you on Monday. So,
yeah. Bye, everybody. Thank you.
so we will be, is now time for our next presenter. Um, it is the Office of Immunizations, and we have, I believe I saw Jessica log in. Um, Hi.
Hello.
Um, and Jessica, I have y'all's slides embedded into our presentation. Would you like me to present them, or would it be easier for you guys to bring them up for
Oh,
you?
if you would like to, that would be fantastic. Thank you.
Yeah, no problem. You might have to bear with me just for a minute.
Happy to flex. It's all good. I appreciate your help. Well, hello, everyone. I'll just start with my name is Jessica Haig. I'm the Office of Immunization Liaison. So I primarily interact and work with our tribal immunization peers and local health jurisdictions, but we also love presenting and being able to participate in meetings like this. So thank you so much for having us. We're going to be covering a couple of different topics. And so some of the topics that'll be covered, will be just kind of the current events of what's happening in the, immunization world, the different federal news, what it all means, all that kind of information. And then we're going to cover, DOH's stance when it comes to the discussion of vaccines and autism. We're not going to talk on it too much. We're just going to clarify the stance DOH has. And then you're going to be hearing from my coworker, Catherine Graff, and she's going to be covering some more clinical components, but as well as, childcare and school vaccine requirements. So thank you. If you want to click 2 slides ahead. Yeah, there's the agenda. Perfect. So I did just want to start with, with everything going on, we do want to assure everybody that the Washington State Department of Health and, and the West Coast Health Alliance, we're all closely monitoring everything that's rapidly evolving. And so we are remaining committed to transparency as updates emerge. And DOH will absolutely continue to keep tribes and partners and the public informed. And we also want to assure everyone that we are actively collaborating with immunization-focused alliances, committees, and boards at both the regional, national levels to align strategy and coordinate response. Next slide. So with the hepatitis B birth dose, so in December, there was a lot of discussion at the CDC level about changing the birth dose. So just to kind of cover it, Washington State's recommendations remains the same. So we affirm science-based recommendations for hepatitis B vaccination at birth. And so we have a blog for you to be able to check out. There for providers, there's the provider FAQs. So, but it's available to the public as well. So please check it out. And so we recommend all newborns the hepatitis B vaccine within 24 hours of birth and complete the 3 to 4 dose series by 18 months, regardless of birth parent hepatitis B status. If the birth parent is positive or status is unknown, the hepatitis B vaccine and the hepatitis B immunoglobulin within 12 hours of birth. And infants born to hepatitis B positive parents, perinatal post-vaccination serologic testing 1 to 2 months after the series is completed, but not before 9 months of age. Next slide, please. All right. So with this is the new schedule that was released on January 5th by HHS and CDC. So a lot had changed. And just to say it plainly, we do not support this change. So this decision reduced a number of vaccinations that are routinely recommended for all U.S. children, and this decision did not follow established procedure for vaccine policy recommendations. So they bypassed the Advisory Committee of Immunization Practice, or ACIP, and public comment process. And so this threatens an increase in vaccine preventable diseases in children nationwide. So children getting sick from diseases prevented by these recommended immunizations leads to missed school for children, missed work for parents, and even hospitalization and death, possibly in some children. Next slide. So this is just to help clarify what the changes were. So on the left, you have the vaccine preventable disease. You have in the middle column, the American Academy of Pediatrics recommendations, which were the previous vaccine recommendations, and we still hold to that. And then what you see in the right column with the red box around it, that these were the changes CDC recommended. So with HPV, their change was for 1 dose instead of 2, but we recommend with AAP, all adolescents, it's a 2-dose series. Dose 1 starts at 9 years of age, and dose 2 is 6 months later. For RSV, it's recommended for all babies under 8 months of age, whereas the new recommendation from CDC says only high-risk groups. For hepatitis A, we recommend all children. The 2 doses were, again, you see on the other side, for high-risk groups only. Hepatitis B, you heard a recommendation earlier. And then the change was, again, for high-risk groups. And if they were to receive it, started giving at 2 months of age. For the meningococcal, for all adolescents, it's a 2-dose, where, again, it was changed to high-risk groups only. Next slide, please. Awesome. So, and then additionally, the other changes were, so for influenza, again, we recommend annually for all children starting 6 months of age, and it's no longer routinely recommended or shared clinical decision making. For COVID-19, they're recommended for all children starting at 6 months of age, where it's no longer routinely recommended. And then for the rotavirus, it's recommended for all children 6 weeks of age minimum, and it's a 2 or 3 dose depending on which vaccine is used, whereas the changes were to be no longer recommended. And so, and I have attached the resources to these at the bottom of that slide. Next slide. So what does all this mean? Basically, the changes in the newly released recommended immunization schedule are not based on new evidence about vaccine safety or effectiveness. Instead, these revisions were driven by a comparison of the number of routine vaccines recommended in the US versus a select few other countries. So without accounting for the differing health systems, disease burden, or access to care. And then these changes, again, were not reviewed by medical or public health experts, healthcare providers, or the public prior to their release. But we do want to highlight that insurance coverage is not expected to change this plan year. So all children and adolescent vaccines should be covered and available by the public and private insurers. Next slide. So I'm just reaffirming again that the Department of Health, Washington State Department of Health, and the West Coast Health Alliance reaffirm our alignment with the American Academy of Pediatrics recommended schedule. And I have attached the resource to these endorsements to it, are reaffirming our alignment. So AAP, American Academy of Pediatrics, so they take into consideration when children are most vulnerable to diseases, when vaccines work best with children's immune systems, the safety of vaccines being recommended, the risk of disease in the US, and all these other different factors. Whereas many organizations, providers, and states feel that wasn't done with this newly released one from HHS. Next slide, please. And then here's just a screen grab of the updated American of Pediatrics. They came out with the 2026 recommendations this week. So here's an image of that. Next slide. And then here, we just want to reaffirm what we've recommended when it comes to respiratory virus immunization recommendations. So DOH, along with the West Coast Health Alliance, we do recommend COVID-19 for all children 6 months of age and older. During pregnancy, it's recommended. For adults, it's recommended. Influenza, again, recommended for children and adults who are 6 months of age and older. RSV, all that are younger than 2 months of age and with certain risk factors. And then there's a few other nuances for pregnancy and adults. Next slide. Okay, so the next slide is going to be very wordy, but I won't read all of it, but you can read it if you would like, because it's also attached on the public-facing webpage. Next slide. So Washington State Department of Health reaffirms that vaccines are a proven essential tool for protecting people's health. And so we agree with health agencies and associations across the country, including the American Academy of Pediatrics and the Autism Science Foundation, in confirming that there is no credible scientific evidence linking vaccines to autism. So DOH is committed to providing Washington residents with guidance based on the best available science, and we encourage people to follow recommended vaccine schedules to protect themselves and their children, and to go to their healthcare providers with any questions and concerns they may have. Next slide. And then on this one, here's a bunch of different resources that you can check out. There's literature reviews, there's links to like Johns Hopkins, and different infographics and posters, depending on the audience and what you might be needing. But there's the Vaccine Confidence Resource Library, and I recommend that you check it out. Next slide, and I believe I will be passing it to my colleague, Catherine.
Thanks, Jessica.
Thank
Hi,
you.
everybody. My name is Catherine Graff, and I am the School and Childcare Immunization Nurse Consultant here in the Office of Immunizations at the Department of Health. So I'm going to talk a little bit with you about this Washington State School and Childcare vaccination requirements. Next slide, please. Next slide. Thank you. Okay, so the Washington School and Child Care requirements are in the RCW linked here. They are for these specific diseases that are determined by the Washington State Board of Health. So these are the diseases for which children must have documentation of immunity. Next slide. So the law says that they must be vaccinated against or provide documentation of immunity against each of the vaccine preventable diseases at ages and intervals in the 2024 CDC Child and Adolescent Recommended Schedule. So even though Jessica just shared with you all of the changes that have happened recently with the recommended schedule from HHS and CDC, we in Washington follow the requirements in the 2024 schedule. So any changes made after that do not impact our school and child care requirements. Next slide, please. So Department of Health is tasked with creating the vaccine requirement charts. So we take that 2024 schedules, the ages and intervals and the number of doses needed, and we convert those into the requirement charts. So there's the child care chart, which is on the left. That chart is based on the age of the child. And then on the right there, you see the school chart, which is based on the grade the child is attending in school. The If a child is in childcare but is actually attending school, so before and after childcare, they need to follow the requirements for their grade on the school chart. There are two links on this slide for the school and child care immunization page, which is the comprehensive page. And then also there's the Vax to School, which is our family friendly page. So the charts are available in multiple languages on both of those pages. Next slide, please. So how the parent documents the immunization for their child to attend school and child care is on the Certificate of Immunization Status form. And then next slide. There are three different acceptable versions of the CIS, the Certificate of Immunization Status form. There are two that are printed from the Washington Immunization Information System, which is our state immunization registry. Those are medically verified, so they don't need any kind of parent or provider verification signature. We have what's called the validated CIS, and then parents can print their own from MyIR, which is a patient portal for their immunization records. We also have the hard copy CIS, which parents can fill out by hand, but it will need to be medically verified either with a healthcare provider signature or the parent can, parent or guardian can just attach the medical vaccination records and the school or child care can verify them for accuracy. There's a lot more information and resources in the CIS section of the school and child care page linked on this slide. Next slide, please. So this is just an example of what the hard copy CIS looks like, just so you understand. And again, when parents or guardians are turning in a CIS, they want to be using the most up-to-date version, which can be found on those two pages, that the websites that I shared with you. Next slide. Now, Washington state law does allow parents to have exemptions for the immunization requirements. So they can be exempted for one or more of the required diseases that require immunization. They do that by filling out a certificate of exemption form, which they turn into the school or child care. Now there's four kinds of exemptions that they can choose. There's personal or philosophical exemptions, but they are not allowed for measles, mumps, or rubella immunization requirements. Then there are religious exemptions, religious membership exemptions, and medical exemptions. There's a lot more information and resources in the exemption section of the school and child care immunization page. Next slide. So this is a copy of an image of what the two sides of the certificate of exemption look like. On one side, you have the personal and philosophical, religious and religious membership exemptions, and on the other side is the medical exemptions. Jessica, did you want to take this part?
Yeah, thank you. So we added this. So if your agency, your organizations needs any information or support public health wise regarding immunizations, please feel free to check out the Washington State Department of Health, public facing web pages for all sorts of information. You can follow, the Washington State Department of Health on social media. So Facebook, Threads, Instagram, Blue Sky, TikTok. And then additionally, you can check out what resources might be in your local area by contacting your local health jurisdiction. We definitely recommend, building relationships between, your community and who immediately provides that support, your local health jurisdiction. So please explore that. And then again, the Confidence Resource Library on our website. But that's what we have. So thank you so much, Catherine, for sharing. And thank you so much for having us here. Happy to answer any questions you might have. Thank you, Iana. Okay. Thank you, Kristen. And thank you, Krisha. All right, Amanda, so that's all we had to share, but if there's any questions, we're here, happy to support.
Okay, well, thank you so much. And if we get any questions, oh, we have a hand.
Oh, we see Jan.
Hi, Jan Schmallenberger in Clark County. When I talk to parents, and there's a lot of us are younger generation parents, they're not necessarily against immunizations and they want immunizations, but they need some assurance of the fear of vaccine injuries, because I think that's floating around there. And so there's a lot of different ways parents are trying to muddle through it. And is there any like really good information on the risk of vaccine injuries versus because CDC has just put a lot of fear and anxiety out there.
So yes, that's the situation we're facing right now is parents are getting more confused and fearful, unfortunately. Well, nothing in the science of vaccination safety has changed. There are some really good resources. We have some at here at DOH. That is there's a page and I can find it. I'll put it in the chat that has some great links to like vaccine confidence. There's other organizations out there too that have some really wonderful resources, and I think some of those are actually linked on our DOH page. But that includes immunize.org, has great resources for families, and so does the Children's Hospital of Philadelphia vaccine um, section that has great resources also. There's a whole family parent kind of group of resources there. Oh, you found it, Jessica. That is awesome. So yes, and having those conversations, it's really important to meet parents where they are to understand their concerns and then be able to they're just trying to do the right thing for their children, like we all are. So it's important to acknowledge that and then try and point them to some of these really good sources where they can find out more information. And I would recommend you guys looking at them too, just so you're familiar with what's out there. I do see another question here from Christy. Says, how are schools in Washington addressing the difference in recommendations from CDC and the Washington state recommendations or requirements for school and child care attendance? So we sent out messaging for the schools so that they are aware that nothing has changed in the immunization requirements because we are pointed at the 2024 schedule. The diseases for which children have to be fully immunized or have an exemption for has not changed. The vaccinations are still available. They can still get them the same way through our childhood vaccine program. So again, we're just communicating that with schools that might have some confusion and with child cares as well, so that they know that it's the same as it's been last year and the year before and moving forward. Are there any other questions? Yes, lots of anxiety with parents.
And a comment on that anxiety. So I just want to reassure everyone that, all of us at DOH, we're humans too with these same interactions, like immediate interactions, like my sister-in-law. I have 3 nieces under 10 and one is 10 months old. And so, my sister-in-law comes to me all the time, like, oh, what about this? What about that? Asking all these different questions. Or my brother will pop in, like, I read this study. So we're always happy to hear those conversations and have them because we do understand the anxiety is real and you're just trying to love and do your best for your child. So we absolutely have that in mind when we put together resources and when we strategize and do what we do. That's why we love doing presentations like this, to be able to connect, hear more. So we really appreciate you having us join you. How are vaccines being paid for those vaccines that CDC no longer recommends? Is there less federal funding coming to the states?
So currently, all of the vaccines on the national schedule, even those with shared clinical decision making that they've changed to that, are still covered on the Vaccine for Children program, which is a federal entitlement program. And so we still receive money here at DOH, and work with other insurance providers and the healthcare authority, et cetera, to provide what we call a universal vaccine program. We're one of the few states that actually has it, and it's so amazing. It allows any child through the age of 18 to be vaccinated free of charge. There's no charge through that program. If they have insurance, the insurance is billed for the vaccine. If they don't have insurance, then they don't have to pay. So there is no barrier financially for any child to be able to receive the vaccines that are required here in Washington State for school and childcare, and more vaccines, even the ones that aren't required, are part of the childhood vaccine program, like influenza and meningococcal vaccine.
Krisha, I see your hand raised.
Yeah, I was wondering about, Catherine, that program, is that follow the EPSDT schedule? So can children that are up through the age of 20 get that, or is it just for following the Vaccine for Children age up until the age till before they turn 19?
Yeah, the Washington Childhood Vaccine Program covers vaccinations through age 18. So if they're older than that, but we do also have an adult vaccine program. It's much smaller, but that one is for people who are uninsured, that they can get vaccinations through the adult vaccine program. It's a different list of vaccines, but a lot of them cross over each other, and during those two things.
Thank you.
Yeah, and we're following that, like I said, for the requirements, it's the 2024 schedule. And Washington is still encouraging providers to, vaccinate per the AAP schedule, which is essentially the same as the 24 schedule of the CDC.
Thank you. What we're finding is if you found it last year and the year before, is that some of our children, sometimes they're children with special healthcare needs, sometimes they're children that have moved and they have already they're turning 19, and so they're falling into that gap. I'm just trying to see if there was a way that we can kind of close that gap up for them.
Right. Yeah. So again, the adult vaccine program is where they would go. They'd need, and there is a map that shows which providers provide both child vaccine and the adult vaccine program vaccines. So yep, there it is, Jessica. Good job. And there is a map, like I said, on that so that people can look, and and the map will actually show what vaccines they carry in the adult vaccine program.
Thank you.
Mm-hmm.
Let's see. I see a comment about the cases in Carolina. Yeah.
Yeah.
Hard time in public health. Yes, yes. During COVID, we preached, listen to the experts, listen to the CDC, but things have changed. Yes, we are noticing that change. And it's very confusing for many. So we do understand that and have compassion for it. But we are trying to utilize the fact that, the most trusted resources or contacts are often your provider, your local health jurisdiction, your state office, Department of Health. So with that, we will always encourage discussions with your provider anytime, every time. So don't think that we're not recommending that. That has always been the case that we recommend it. So please always feel free to have a discussion with your provider. Absolutely. I see Raquel, vaccination is very important and the benefits are well known. Yes. And yes, looking at a cultural perspective is definitely important. Language barriers and gaps in communication. Yeah, you're bringing up great points, Raquel, in this comment. It's beautiful. Yeah. Oh, Amanda, I see your hand up.
I just had a question because I constantly see about with the resurgence of measles that we're gonna possibly lose our eradication status, and I was wondering if you could explain to us what that would mean if the United States were to lose that.
So we have the measles elimination status that we've had for 20 years. And what that means is that there has been no one outbreak of measles that has been sustained for 12 months. So if the measles we've had measles cases every year, but a few, and we've had some outbreaks that are larger. The most recent larger outbreak in 2019 was quite large, but those didn't sustain for 12 months. And most of our measles cases have been imported. So it's not an endemic transmission. In other words, it's not just living in its reservoir here in Washington State or in the United States. So it's usually brought in by foreign travel, usually US citizens traveling out of the country or residents traveling out of the country and then coming back and bringing measles with them. And the large majority of cases are in unvaccinated persons. So that measles elimination status, it'll be reviewed in April, I think. And if we're a sustained outbreak, which is likely to be the case, truthfully, for 12 months, then we just lose that status. What that means is that we have cases of measles that are feeding each other kind of as an ongoing thing here in the United States. It doesn't change vaccine access. It doesn't change, policy in that way, but it just means that we've had so many cases that they're just continuing now. Canada, I think, has already lost its status, and Great Britain just lost its measles elimination status. So it's really unfortunate to see, and it's directly due to decreasing vaccination rates. Measles is a very, very contagious. It's the most contagious vaccine preventable disease. And so it needs a really high number of people vaccinated. That's 95% in a community to stop the transmission spread. And we do have pockets where there's lower rates of immunity. And measles, while the MMR vaccine, while it is a very, very effective vaccine, and not everybody responds. So even sometimes people who are vaccinated can be vulnerable to measles, which is all the more reason that we need to protect the whole community by having high vaccination rates. One dose of measles vaccine provides about 93% effective. People will be immune after one dose, but that extra dose is needed for children because of that 4% to take them up to that 97% immune. We need that extra dose, so that those 4% extra are the ones that will respond after the second dose. And now we have that community immunity that we need. And then some people, of course, can't be vaccinated because of medical problems. So we want to make sure, the whole community is protected, which is part of why we have the school and childcare requirements. Every child in school, deserves to have a safe place to attend, even those that can't be vaccinated or don't respond to the vaccines. That was my soapbox, sorry.
It was excellent. Thank you. There is another question from Jan. Many families are seeking medical care from naturopath providers. Do you feel that they routinely recommend the standard 2024 vaccine schedule for their pediatric patients?
There are a lot of naturopaths who do, who do encourage vaccinations. I don't know a percentage of maybe ones that do or don't, but I know that there's a lot of naturopaths out there that are real vaccine advocates and want their patients protected.
Yeah, a personal anecdote. I've worked with a naturopath and they were supportive of vaccines. Again, I don't have children, so I didn't get into that discussion with them, but adults, absolutely. So I'm sure there's quite a few who are supportive of it.
This is Monica. I just wanted to get back to Raquel's question, and I'm wondering if there are ways for community-based organizations to connect with your team, if they would like to do some more outreach to families, or if you have specific resources to share for that more kind of inclusive, culturally relevant vaccine information for community-based organizations to be able to share with their clients.
Yeah, we've worked a lot with the community collaborative done here through DOH. I'm not sure if many of you know it, but I could put the link to it in here. What we're recommending is absolutely check out our web pages, the links that we shared in the resources, absolutely check them out. What we're recommending is you can always reach out to us, absolutely, but to really start partnering with your local health jurisdictions, because that way there's a lot of connection on what's happening in your local area. And there's a lot of resources and there's a lot of CHWs, so community health workers at local health jurisdictions that can help support. I know I'm working on a project with some great team members throughout the Department of Health, not just OI, on a community health worker toolkit about vaccine confidence and how to support and recommend and have discussions. So there's a lot of resources in the works, and there's a lot of resources that, like I live in Kitsap. There's a lot of resources I know their LHJ has. There's a lot of resources I know in Okanagan. And so there's a lot of great resources at the county level as well that are specific to the communities in your local area. So I really recommend that connection and partnership. And we're always happy to attend and present as availability allows. Oh, thank you for adding that, Monica. I hope that answered the question. If not, I can go deeper into the weeds if there's more nuance you would like. Yes. So I believe the toolkit, like the pilot, I'm not in charge of it. I'm just one of the subject matter experts connected to it to for the Office of Immunization to help influence, clinical and accuracy. But I believe there's like a little pilot that's going to happen sometime March or April, and then it'll be available more widely a few months after that, from my understanding. I have a meeting today, so I'll find out more. So I'm very excited about it. It's looking good. All right. Well, I see another one. With child cares, will there be more overlap with DOH, DCYF for immunization resources?
So I do work with the health analyst at DCYF to share information that we have that's applicable to childcare's and early learning programs. So we do collaborate, and we encourage them to use our resources as well. They don't have, I don't think, as deep of they don't have as many resources around immunization, so they usually refer people back to us, our DOH website, and us if there are more questions and details that they need. But we do collaborate with them, and we also collaborate with OSPI for schools, and then with the State Board of Education for private schools as well. I just want to add that if there are immunization resources that we don't have, that you think would be really helpful, to let us know. That's how we find out, more about the needs. And we, like I said, we talked to OSPI and DCYF, et cetera. But you guys, if you guys are hearing that a particular resource might be really helpful, do reach out to us and let us know.
This is Monica. Just to add there, I think one of the things that would be helpful, and I know we've had some conversations with our OPI team around this piece, is having some specific information around children and youth with special healthcare needs and impacts to that population. It tends, immunization rates can impact our population where, some children might not be able to get immunizations for particular reasons, or maybe more vulnerable to different types of infectious diseases. So I think that from our perspective, that would be one thing that I think would be helpful for the families that we serve and the local health jurisdiction partners that are here.
I think that's excellent. In that meeting that I will be in about the CHW toolkit, I can bring that up as a discussion because OPI, or the Office of Public Affairs, but they have a health education promotion team. So I can absolutely have that discussion with them. Love the resources that King County put out on childcare for measles preparation. Let's see.
Yeah, that's a great resource. It is.
Yeah, and that's what I was really encouraging, getting to know the local health jurisdictions, LHJs, because many local health jurisdictions have resources like this, and it often reflects the community within their jurisdiction or county. And so it's beautiful. A lot of the content, the toolkits, resources, all of the above. That's why we're really recommending those relationships. And we have close relationships with the LHJs as well. And we support them however they request. Absolutely. We love seeing content like this. So I'm really glad you saw that.
Many of the participants in the room are what are called Chiskin coordinators, and many of them are stationed at local health jurisdictions.
That's great.
And some of our participants are from neurodevelopmental centers of excellence. So they're throughout the state. Just so we have a couple of, like, I know Krisha is at Okinawan. So she is at the health department there, or local health jurisdiction. So, but she is the Chiskin coordinator as part of her role there. So yeah, so we have some ties as well. So they are very much plugged into our communities and they know what's going on. But they also, I know any resources many of our peeps would love to.
Yeah, absolutely. And because I'm like, I see a few names on here that I send emails out to for, office hours meetings. So like Elizabeth and Chrisette, I know those names. I've met most of you. So that's fantastic. And so we do, just to have this discussion as well, we do have many trainings that are like to support LHJs, tribes, in the kind of the trickle down effect. And so we do have those meetings. They can email me anytime. And I love seeing and hearing what they're doing. I know Elizabeth does a lot of great work in Mason County. And so I was able to visit them and see what they do. It's amazing. So we're all really connected. So always feel free to reach out. It might be a delay in response sometimes, but we absolutely want to hear from you and happy to have conversations.
It's amazing how we continue to find all of the overlaps that we have. because I didn't not even know that we had some doing immunizations and some who are just skin coordinators. So things I know find out every day.
They're rock stars. Many of them wear so many hats, and they're just doing beautiful work and like merging and blending it on so many different fields. So great people to work with. I'm glad you know them.
Yes, I am too. I got to meet some of them in person and it was the best
Great.
time ever.
Oh, that's great.
Is there any more questions that we have for our folks here? I think we have about 5 more minutes with them and then we have to let them go. So
I did put our division, so the Office of Immunization email, I did put that in the chat. So if you have questions after this or suggestions on resources or just letting us know kind of a general like community consensus that you might be hearing in your local community, always feel free to email that to us. But yeah, we're here if you need.
I think anything too specifically, like Monica mentioned, like ideas
Yes.
around Chiskin too, I think that might be good. So any ideas around that as well, might be beneficial as you move forward.
Absolutely. Yeah, I wrote it down just now to bring it up in my meeting this afternoon. Actually, it's my next meeting, but I will be bringing it to that one. So thank you for suggesting that.
Okay. All right. Well, I won't let everybody sit in awkward silence for too much longer. So if there's not anything else, we can move forward. We have a break coming up. And thank you, Jessica and Catherine. We appreciate your time and your education. I appreciate it so much.
Well, thanks for giving us a chance to be here and talk with you guys. So yeah,
Yeah,
take
thank
care,
you.
everybody.
Yeah,
Thank you,
everyone.
all. Awesome. It looks like we got everybody who is back. So what we are going to be doing next is it was identified last year when we were working on CommNet evaluations and going through them that there was a desire for more interactive sessions. So we're going to take about 25 minutes to design how these sessions should be and how we desire for them to be. And hopefully we can get some good information so that we can directly implement them for the future. This will be done via Zoom polls just because of the length of time that we have. We won't have time to like do all discussion in the chat polls or anything like that. And like I said, we're using this information to directly impact the future of our interactive CommNet sessions. So that being said, I really hope you all participate, but I understand we're 2 hours into this meeting, and if you need a break, you need a break. So I'm gonna get started. Linda is my co-pilot here, and she will be launching the Zoom polls. And what I'm going to be doing is bringing up the question, and it will have kind of what it will be influencing, like what part of the interactive section it will be influencing, what the question is about, And then what the options are going to be will be in the question itself. But let's get started. So, level of structure. How structured should ComNet interactive sessions be? So very structured, clear prompts, guided facilitation, some structure with room for open discussion, and mostly open conversation. And I'm going to give us some time to answer those.
This is Monica. I will just add that I also put the question, I'm going to put the questions in the chat as we go through them. So if you have specific, open-ended responses that you want to share, you can feel free to do that in the chat as well after you've answered the.
So let's try to stay on like one at a time though, because I see people are going beyond one. So let's try to do one at a time just so we're not getting too far ahead.
Amanda,
And
this is
currently,
Stephanie. Oh,
hey, Stephanie.
sorry. Quick question. So maybe I missed this. Are we doing one question at a time on the entire poll, or are there multiple polls and we're doing the entire poll at once?
So we're just doing one question at a time on the poll. It was one question at a time on the poll. So we're gonna do question one and then pause for a little bit, hopefully get some good number feedback, and then because right now we have 54% participants and only 24 people are answering.
Okay. Sounds
Yeah.
good. Thank you.
Yeah, thank you for asking that. That helps hopefully clarify things for a couple of people. So right now with only half of the group answering, we have for question number one, how structured should ConMet interactive sessions be? Some structure with room for open discussion is the majority at 96%. Next question. What participation options should always be available? And this one is you can select multiple choices. Listening only, chat or written responses, speaking in the group, polls or quick questions. So which option should always be available to the group?
And you may need to scroll down to see the rest of the question too.
Linda, after people responded, it disappeared. Can you reopen it for people?
I don't know how to do that, and I don't know if that's an option. It gives me an option to end the poll, but it will end for everyone.
Yep, that's what I was thinking too.
Might be something with the more button. You might be able to get back to it that way. I'm not sure. And if you can't get back to it and want to make a comment, you can do something in the chat for that particular question.
I also created a QR code for it. It should take you back to it too. It's in the chat. You just got to use your phone to do it. Sorry for the technical error. All great technology. Okay. Focus of interaction. How focused should interactive portions of CONMET be? The questions the question is, what should interactive portions generally focus on? And we're going to select just one. So the options are one clearly defined question or prompt, a small set of related prompts, or an open discussion shaped by participants. So next, we have non-negotiable guardrails. What guardrails should always be in place for ConNet interactive session? Pardon me for my stutter a little bit. Clear purpose stated up front. You can choose select up to 3. Multiple ways to participate. Ability to pass without explanation. Strong facilitation and time boundaries. Respect for different roles and experiences. And clear expectations for interactions. For this one, we have quite a tie going on. So clear purpose stated up front and multiple ways to participate. And respect for different roles and experiences are the front runners currently. So just make sure you get your vote in. And then the next question I have is there anything that should never be expected in an interactive session? So is there a guardrail that we missed or something that should never be expected in an interactive session? And you're welcome to put that in the chat or in the long answer portion or either of those places is fine. And then the next question is consistency across sessions. How consistent should the interactive structure be across ComNet sessions? Very consistent, mostly consistent with some variation, or flexible depending on topics. So it just, which one would you like to see? All right. So I'm sharing the results out with everybody just so we can see what we have. It looks like that for the first one, so we're looking at some structure with room for open discussion. Which participation options should always be available. The largest one was chat or written response with listening and speaking kind of. They definitely came in and they were a tie, and polls or quick questions coming in second. And then what should interactive portions generally focus on? 50% of you all said a small set of related prompts. And then what guardrails should always be built into interactive section or sessions, and a clear purpose stated up front was the winner here. And multiple ways to participate, and the ability to pass without explanation were the winners there. And a couple of folks answered that there was a guardrail that wasn't mentioned above, so we can look at those and see what those would be.
I'm able to see those, Amanda, if you want me to summarize those real quick.
Sure.
One recommendation to have participants come with a potential situation to discuss with the group and have it flow organically. Another suggestion to send out guidance or questions beforehand so people can think of things better and not as much pressure in that moment. Also, having the ability to share it afterwards, so it's more feedback kind of interaction. Having a good guidance and facilitator for the sessions, preferences for a variety of topics. But previous sessions have not been very useful in terms of the interactive sessions that have happened so far. Just having that ability for conversation to evolve organically, and just folks that love it as it is now.
Okay. Thank you for that. Thank you for sharing those. And then the last question we have is, how consistent should interactive structure be across ComNet sessions? And then mostly consistent and flexible were our top two, tying. So I guess we'll go in the middle. We'll try. But thank you for everybody who participated. This will help. And we'll make a plan and take it back to the team. But without you all, ComNet doesn't happen. So Thank you again for your participation. And we have one more presenter this afternoon. And I'm going to stop sharing my slides because they have their own. And it is from our Office of Genetics. And Maddie, take it away.
Thanks, Amanda. Here, let me share. Oh, it's saying, could you share the host abilities with me, please?
Linda, please.
Cool. Oh, there we go. Okay. Is that sharing the right screen? Does that look right to everyone? I'm also realizing I don't know if I can see the reactions even with multiple screens.
It looks good. Can you see
All right,
it?
wonderful. Thanks, Monica. All right, well, that was kind of a good intro because I was actually hoping today was a little bit more interactive. And if I remember the results, totally feel free to put things in the chat or come off mute. That's totally fine. But yeah, my name is Maddie. I'm in the genetics program here at the Washington State Department of Health. Today I wanted to present a draft resource that we've created with partners. Chiskin gave us a lot of feedback on this resource, really in an effort to better support families before, during, and after a genetic appointment. So today really the ask is to provide your thoughts, feedback, reactions with this current draft. Just because it's not super digestible right now, I didn't do like screenshots of it. I kind of in broad strokes what each section covers. We definitely don't want to frame genetics like we're trying to prioritize it over any other services that all of you are doing, but ensure that this final version does address the needs and barriers that Chiskin families face in accessing genetic information and services. But for folks that aren't familiar with our program, really, we're focused on increasing awareness of genetics, improving access to genetic services for people with or at risk for genetic conditions. I know today is mostly like focused on pediatrics with children and youth with special healthcare needs, but our program is really designed to help people, support people across the lifespan, wherever genetics becomes relevant. Generally speaking, I would say a lot of our work is in the between spaces outside of clinical care, before a referral is made or after a genetic diagnosis has happened. And a lot of that happens through partnerships with other programs like Chiskin, like family organizations, community organizations, healthcare providers who either work with populations that, you know, they're working with people with genetic diagnoses or, you know, where genetics intersects with that work. And that looks different depending on everyone's specific needs, the population they serve's needs. Sometimes it's connecting people to genetic providers. Sometimes it's offering technical support, education to providers, curating, creating resources, one of which you will be seeing snippets of here shortly. Linda reached out to me about some interest in learning a little bit more about our mobile genetic clinics. That's definitely aligned with our access to genetic services part of our mission. I personally don't manage that contract, but so like very detailed details I don't have. The person is out this month, but I do know we have a contract with Seattle Children's Hospital, and that allows, you know, genetic services to get out of the Seattle metropolitan area. Historically, that's been in Yakima, Tri-Cities, Wenatchee. I know within this contract, we have a few more clinics that are going to happen before July. I don't know the specifics, like the specific dates and the specific locations. If that's an interest to anyone, drop that in the chat. I can reach out to our connections at Seattle Children's. We also have a genetic clinic directory. So if you're wanting to make connections with your local or nearest genetic provider, always happy to help with that. So feel free to reach out there as well. But, you know, getting back to this work with Chiskin, the intersections with genetics and children and youth with special healthcare needs, you might be wondering where that intersection started. And I think it's helpful to think about how genetics relates to our overall health. Of course, our health is shaped by many factors. I like to kind of think of it like a puzzle, you know, the environment, lifestyle, life experiences, and our genetics shape our overall health. Most often, it's a combination of all of these factors. It's pretty balanced puzzle, if you will. That said, for children with special healthcare needs, especially if they're medically complex or have multiple health conditions, the possibility that the genetic piece of this health puzzle, it may be a little bit larger and become a little bit more relevant to their medical care. Not because it's going to explain everything, but it can help explain why maybe certain things are happening together. One example of this is with complex autism spectrum. So someone that has autism and then maybe some other medical concerns like epilepsy or some learning differences. When genetic testing is done, there is an identifiable genetic difference in about 4 out of 10 of those kiddos. And that genetic finding often represents a broader medical picture or syndrome. You may have heard that term before. So it really helps connect certain medical concerns with developmental differences, learning needs that might otherwise feel unrelated. So understanding that genetic piece can help families understand other health needs, like whether additional screens or referrals may be helpful given that genetic condition, like some complex autism spectrum, some conditions that are associated with it, they're going to want cardiac screenings or renal screenings. So it can support that personalized care planning for families. And in addition to providing condition-specific support resources, a lot of genetic conditions have organizations dedicated to the lived experiences of people with that genetic condition. Just one example of the thousands and thousands of examples out there, but it highlights the potential benefits of genetics and what it can provide for Chiskin families, which is where this all began, really. However, these benefits, families don't automatically access them. And with pediatric genetic appointments, it kind of has to do with its the structure and positionality of where it is housed in our medical system. So pediatric genetic appointments, these are currently a specialty healthcare service. So they require referral, either a pediatrician or another specialist involved in the family's care. They have to recognize those patterns that are associated with a genetic condition. Once a family, makes it to that appointment, it's often led by a medical professional called a genetic counselor. You may have heard this appointment called genetic counseling. And in the pediatric setting, families often meet with a medical geneticist as well. So this is a doctor who specializes in genetics. And because of this, appointments typically take longer. They are more conversation-based as well to support informed decision-making surrounding genetic testing. This type of service is very non-directive. The goal is never that the family gets genetic testing. It's really that, they're provided balanced information about their options when it comes to genetics, and the providers help them make an informed decision and support them in whatever decision they make. But this model, this like 2-provider model, the specialty model, it really creates barriers for families. And there are major systemic barriers within our medical system. Many families, providers aren't aware that genetic services are even an option, or how it could relate to a diagnosis or a set of diagnoses. They don't know how to access the referrals. Where do I send these types of indications, and then the wait times, sometimes months to even longer, unfortunately. And has a lot to do with the shortage of medical geneticists in our country, globally, actually. And yeah, during those wait times, families are often, it can be an uncertain time. And of course, this is not across the board, but there can be a lot of uncertainty. What will that appointment look like? What does genetics mean? Where do I go for reliable information? So those types of challenges shaped how we thought about what could be most helpful outside the appointment itself. And we felt kind of like this family-centered booklet would be a best next step, something that provides the context, provides linkages to genetic providers, and other public health programs, community organizations that are available to support them no matter where they are in that genetic journey, as well as some action items. Having some actions can feel, helpful for some people. I know it's not universal, but that was kind of the direction we landed on. It's been a very iterative process, but prior to developing everything, we were able to identify a lot of great resources, like specific to certain pieces to a genetic appointment, like family health history collection. Many of you are probably aware of all of the wonderful resources Seattle Children offers in the context of genetics. These are valuable, important. This type of resource is definitely not meant to replace, institution-specific resources. But we wanted something that was kind of a one-stop shop, kind of covers what that experience could look like for families, and make it more agnostic. It's not tied to one health institution. So now kind of shifting into the resource content itself, we really want to ensure that it reflects real experiences, addresses any gaps that maybe any of you have experienced or have heard from families. So as we move through each of these section overviews, really interested in hearing your perspectives. And okay, wait, no, I did just see, I was just gonna call out the chat again. And I was like, you can drop things in the chat or come off mute. I'm comfortable with either. How does this change things? Oh, it does pop up onto my screen. I'm sorry, everyone. I'm a Teams human. I need more practice with Zoom. Okay, so I have access to the chat if that's more comfortable for folks. But again, just wanting to know think about what would be most helpful at this time point, what feels missing or unclear. But before I go forward into the content, did anyone have any questions or thoughts, reactions on anything that I've covered so far? Okay, I'm not seeing anything. We have a few more slides to get through. So, alrighty. So, maybe. There we go. So we decided on, again, it's been very iterative. I think we first started on kind of grouping things by genetic concept. Through feedback, it kind of felt a little bit too medical. Again, we want to try and capture that experience. So we deferred to the kind of like a timeline format to structure the content. I'm not a graphic designer, so these snippets on the left half of the screen, that is the current cover page and table of contents to the booklet. We wanted to provide some context, what this booklet covers, and then the ability for a user or reader to jump through to each section that is most relevant to where they're at in their journey. And then also a communication pathway felt important for people that maybe want more information or more specific information that we just can't cover in a resource intended for the general public. And if anyone's familiar with the newborn screening or a lot of the DOH resources are, and the Chiskin resources are great inspiration on the graphic design front. We're definitely going graphics, photos, color, breaking up walls of text wherever possible. So that's the goal there. So the only thing before I move into the next section, I do just want to quickly point out how a genetic appointment can help. I didn't do a slide for that one just because we essentially have covered it, the context, where genetics fits into our the healthcare system, where to find a genetic providers in that section, and community support resources. So Chiskin helped us kind of collate some great community support resources in addition to all of the wonderful work that the Chiskin team is doing. If anyone has any thoughts on any additions to those types of community support resources that we should incorporate in a resource like this, definitely feel free. Thank you so much, Monica, for dropping that in the chat. But any thoughts or questions with these first couple of pages? Okie dokie, I'm gonna go forward. So before a genetic appointment, this is oftentimes the longest part of the journey because of those barriers that I mentioned a couple slides back. So we thought this might be a good time. This might be a good time to focus on some reflection and preparation, just so there's less pressure when they get to that appointment to have, all the answers for the providers when it comes to family history or your goals. So I think I mentioned it in the overview slide, but this appointment, a genetic appointment, is very non-directive, and the genetic counselor really wants to tailor that shared decision making to the family's goals and wants and values. So they ask very similar reflective questions that we have in this booklet. And I don't think I mentioned it. My educational background, some of my professional background is in genetic counseling, and from those experiences and conversations with other genetic counselors, those questions sometimes throw people off. So yeah, I just thought to kind of give a plug there for individuals and families just to be prepared for those types of reflective questions. This section also has guidance on family health history collection. So families typically share genetic information. It's, of course, not everyone, but typically they share genetic information. So it's another tool that genetic providers use to look for patterns or clues that may indicate a genetic condition. So that can be one way to prepare for a genetic appointment. There is reminders in there that genetic clinics, they typically have their own forms. Of course, they're very medical. We want this to be very family friendly. We love this Heart Foundation family tree kind of format. Going to go to graphic design with that idea. But that pretty much sums up that section of the resource. Does anyone have any thoughts or reactions to anything there, or does anything feel missing from that section? Okay. Something that I actually thought of this morning, and I was like, should I bring that up? Create maybe problems, because it is a complicated issue in genetics. And I feel we had this in a previous iteration and it just got lost along the way. But does anyone feel that information on cost or insurance coverage would be valuable in this section, or perhaps in the, before you even get into this genetic workflow, like how a genetic appointment can help? Great. Janet, do do they need to bring specific information to the before appointment? So maybe this language isn't clear, and that's something to consider. So the before the genetic appointment, that's like before they even are seen in a clinic. Maybe a referral has been placed, or maybe they're even still just considering a genetic appointment. So yeah, this section isn't really for a clinical genetic appointment yet. But to, I guess, like complete this section and be like, overly prepared for your genetic appointment, thinking through your goals and, what you're hoping to achieve from this appointment and the family health history is definitely something that they can do in that oftentimes long waiting period to see a genetic appointment. Does that clarify your question, Janet? And I'm just going to make a note to consider adding insurance to the before.
I wonder, even just because sometimes that can take time for families to gather that information, like if there are other things besides the family health history that might be needed even in the before your appointment thing, just preparing families for information they might need to.
Yeah. I know it's like primarily the family health history because that takes up a big chunk of the longer wait appointment time. So having that will be huge for the appointment, but yeah, insurance is definitely another piece. But at the before, it would be coverage of genetic counseling because the genetic appointment is determining if a genetic assessment, genetic testing is, wanted or needed, recommended based on national guidelines. I guess, long story short, I guess I need to think about what exactly would be the ask for families. Is it, checking the CPT code for genetic counseling? But yeah, that's a really good point. And it's something that they could definitely do before the appointment. I need to talk to more genetic counselors, practicing genetic counselors too, if that would be helpful to have them go through the prior authorization for, well, no, because they wouldn't know what genetic test would be recommended at that point. Yeah, I'll think about that more. Insurance, cost, important pieces. Amanda, I think I see your hand up.
Yeah, I was just gonna say, like maybe if they only have access to one parent's genetic history, like what do you recommend in that situation? Because it says when possible. I mean,
that was getting at that point exactly, because yeah, not everyone has access to their family health history, adoption, estrangement, things like that. It's one tool that the genetic providers can use. They're flexible. They will work with whatever you have. If you don't have that information, there is, and I think it's actually on the next slide, there's other assessments that they do in the pediatric setting. They do a physical examination to look for more patterns or clues that may indicate a certain genetic condition. They go through the medical history, a lot of times pregnancy history, if that's available. So it is one tool, but it's not the only tool. And that might be a good context to add to that section because a lot of people, I mean, myself included, I don't have access to a lot of my family health history. So yeah, that's another challenge that families face.
Well, even just saying like, don't panic. Like,
yes. Yeah.
Gather what you can and one's like, the one side would be useful, make sure you have that information on hand when you go to your appointment, but the perfectionist in me would be flip-flopping around on the ground like a fish, going, I wish I had it for you.
Yeah, something that we also really wanted to do with this is just to normalize all of the feelings that can come up throughout this process. And that is definitely a big one. Like, yeah, the stress, anxiety of like, I don't have this information. Does that mean I can't get this service or, coverage for this service? Oh, that's another barrier. Insurance is, and I should have worked it into this presentation better. And I apologize, everyone. Insurance is very frustrating when it comes to genetic services. But I will work that out better offline. But the family health history, we can definitely provide reassurance, because in other ways in the resource, we try to provide reassurance. Just looking at a couple of comments in the chat. So rural communities, they will have to figure out travel to the appointment, especially if they are using people to people for support. That is a really good point. Traveling, those types, childcare, those types of things. I wasn't sure if we should go into that level of depth for this, but I mean, it's definitely relevant, especially because it is a longer appointment. And I know that there are public health programs that they're lost on me right now, the names of them, but I know that there are services that help people get to appointments. That's a good point. I can make a note of that. And then the hybrid tools, family history for families to use, that could be something they could access on their phone so they can add to and share at appointment. There are family health history tools. There's a lot out there. And so there's a reminder in this section about how clinics usually have their own tools. Sometimes they are hybrid, online or on a phone, and they send those out before the appointment. I wasn't sure if we should. It gets a little complicated, I guess, us being the DOH. It's difficult to endorse or use one of those tools because a lot of them are for-profit companies. So it's hard to incorporate that. But something like a form, like this family health history tree is like this organization created it, intended to have it printed out. And write on it. I don't know if that's the most accessible option, but here at the DOH, graphic designers might be able to create a fillable form of sorts with their magic that could be filled out on a phone and saved to the device. I think there's a lot of, wise fear right now about inputting personal information. We would have to think more about that and how to make it so it's not, not linked to any one individual, but still available to the general public. Really good points, everyone.
I think Krisha has her hand.
Oh, thank you for pointing that out.
I was asking the question, but the other thing I was thinking was more with going with family members when they're going to like a specialist appointment, which this is kind of like that specialty, is not the tool the tool would be for the person to be able to fill out. And so that they have that like kind of like your My Chart, so that when the person comes in, it's kind of like a reminder of what kind of questions to kind of ground them to where when someone starts to ask them those questions, they have that available for themselves to kind of go over. So they're not having to think on their feet and trying to recreate or find something. So something that's available to them that they can, I know that with going with my father, it was a very long appointment for a cancer to go through all of the family history. And if I wasn't there, he may not have remembered, some of the things because he doesn't know all of the things with his family.
Exactly. So. Yeah. And that's a lot of families are like that. They have like a health historian that a lot of family members go to. And that's why it seemed appropriate to put kind of those guiding questions in this section because it's very time consuming, especially like for I'm a millennial, and I rely on my mom and dad for a lot of information, and having those conversations take a lot of time. So yeah, I think that waiting period allows it. It's really frustrating. I know it's really frustrating for a lot of families, but it is something that they can do if they want. I am realizing I did not give myself enough time. We're at 20, my clock is showing 28 minutes. The next section is of course, during the appointment, just to provide some context so families can prepare. I guess getting at the point about travel and maybe, childcare, those types of like logistics. They are longer appointments, can be 30 minutes up to 2 hours. And that's really grounded in that informed decision making around genetic testing, allows time to share questions, concerns, review family history. Pediatric setting, they almost always want to do a physical examination to look for subtle patterns or clues that are associated with genetic conditions. Genetic testing may be discussed depending on all of those findings. Sometimes it doesn't provide any new information, and every appointment's going to be different. For families that decide to pursue genetic testing, this section provides information on the type of tests that are typically offered, the samples that are typically collected, the types of results that could come back, and ways to plan how they would like to receive the results. And then for people that decide that this is not something they want to pursue, of course, they're supported. Any questions are answered. Provider moves on to supports. What else can we do to help you and, your family? It could be other referrals, insurance guidance, IEP kind of stuff sometimes. But yeah, really the goal of this section is to set expectations and reduce uncertainty under what this appointment looks like. It is very similar to a lot of medical appointments, but there is some unique qualities to it that it's helpful to understand and prepare for. But I want to be respectful of everyone's time. I don't think we're going to be able to get through it all today, unfortunately. So
I don't know if you have availability to stay on longer or not, because we do have a open networking hour coming up next. So if you wanted to stay on, and for those folks that can stay, that's
yeah. This is usually like my lunchtime, so I'm happy to stay on. And if anyone is available to stay on, I'm happy to hear your thoughts and feedback on this. Wonderful. Yay. Awesome. Thank you, Monica. So that's the general overview of this section. It's very text heavy right now. Again, not a graphic designer, but we looking to other great content out there, genetic content for inspiration, like trying to use graphics to break up some of this information. But does anyone have any reactions to this? Is there something that you expected in this section and didn't see? Let me pull up the chat again. Oh, dang. Are we seeing we may not have ASL?
ASL interpretation. Yes, we will not have that for the noon portion. I don't know that.
Is that okay?
I think it's okay to go forward. I'm not sure if anybody was specifically requested that for today. It's more of a accommodation that we provide for the meeting. Let's see. I do see a question in the comment in the chat from Janet about a reminder to reach out to parent-to-parent coordinators in their county.
Love that. Would parent-to-parent is through PAVE, correct? Am I remembering that right?
It's through the Arc of Washington, and there's parent to parents in it that serve every county. So there's different local parent to parents.
Yeah, that I asked just because that is the ARC and PAVE were two community organizations that we had discussed are resources to families that are on this journey and can access them no matter where they're at in the journey or whether it's genetic needs or not. So yeah, we do have the ARC in there, but we can I'm imagining there's a directory of the parent-to-parent coordinators. Like, is there a searchable
Yeah,
or
we can
filterable?
we can put that in the
Yeah, I can see that fitting into that section for sure. Thank you, Janet. Okay. And at this point, the family will get connected to so many support resources if there is needs there. We have like a section that outlines possible supports that genetic providers can offer families, and I believe one of those was like community support. So if they don't capture it earlier, then the genetic provider, genetic counselor usually will be the one to help coordinate that. Okay, so I am going to go to the next section.
Yeah, I see another comment from
Oh.
Gabriella. She has a niece who she believes had some genetic testing as a young child, and unfortunately, there was not a lot of follow-up done. And recently turned 18. Are there resources to help her go through some follow-ups with this information?
Oh,
Would you have
100%. Yes. So adult 18. Yes. I would first direct you or your niece to the are they well, I guess you don't have to disclose. Washington, we have a directory. There's a directory that we maintain where you can find the nearest genetic provider. If they're not in Washington, if you Google find a genetic counselor, I think if you just Google findageneticcounselor.com, let me see if I can get it real quick. I don't remember if it's .com or .org. I should know that. Sorry, everyone. It's through the National Society of Genetic Counselors. Alrighty. So that is an option if they're out of Washington state, but we also have our genetic clinic directory. Link, sorry. That you can filter. So at this point, if they had pediatric genetic services way back when, at this point, since they're 18, I would start with adult genetic services first, because most locations do adult indications that are not cancer related. So those are a couple of options. Screen here. Is there another question here in the chat? Yes, of course, anytime. And if anyone is having on the call ever wants help connecting to local genetic provider, genetic clinic, feel free to reach out. We're happy to do a warm handoff. Alrighty, any other feedback on the during your genetic appointment section? Alright, I'm gonna go forward. So afterwards, It's another waiting period, primarily if the family decides they want to pursue genetic testing, and the turnaround time for genetic testing varies highly. It usually depends on the complexity, or like how wide of a net they're casting to try and figure out if there's something genetic going on. After that context section of the after your genetic appointment, we help the reader understand what happens when the results are ready, providing an overview of that results disclosure, what next steps look like given types of results returned. Sometimes, and that again is going to vary depending on the type of results, but sometimes it's reevaluation, sometimes it's more testing, sometimes it's care changes. Like if a genetic condition is identified and the family isn't already doing some either preventative screenings or seeing a certain specialist, for example. Something that I think is really relevant to the pediatric setting is that genetics doesn't have to be a one-time service. I think a lot of times people think of specialty care. At least I did before I got into this space. I thought of specialty care as like a one time. I go there, done. It doesn't have to be that way, especially with genetics, and especially as kids grow up and start to ask questions about their bodies or like what this meant or anything like that. So the genetic team always remains a source of ongoing support for families, and also another layer of context here is, if a genetic condition wasn't identified, over time, we learn new things, our technology advances. Sometimes we don't find something because it's a limitation of where we're at in our understanding of genetics and our technology. It is, relatively speaking, a newer field, so we're learning new things every single day. And genetic counselors usually let families know that, like, hey, I know this didn't provide any answers. How about you check in about 3 to 5 years? And then the final point to the booklet is just directing the reader back to the public health programs like Chiskin or the community organizations at the beginning of the booklet. No matter the outcome of the genetic appointment, they can find community and a sense of belonging. So that wraps up where we're at right now with the resource, really trying to illustrate how families experience genetics and provide the most relevant information at each point of that journey. Any thoughts or questions with this section? Anything feel missing? Okay, cool. So this is a family resource, so we definitely envision families using it to either prepare for a genetic appointment, if they're considering a genetic appointment, allowing some of that context and information for them to maybe even make an informed decision to pursue this possibility. For care coordinators, healthcare providers, it can be shared, at referral or, to assist in the expectation setting because of some of those unique qualities of a genetic appointment, and really allowed to reduce some of the uncertainty around genetics and, some of these situations where families may be navigating multiple diagnoses and there's not any one thing that's connecting all of them. Importantly, this resource is not meant to replace any of the incredible work any of you are doing when it comes to navigating genetic appointments with families, or especially not meant to replace genetic appointments entirely. But yeah, we hope that the final version, after graphic design, it's going to meet those needs that we talked about. Yeah, that was the overview I wanted to give with the draft. Did anyone have any other feedback with this direction that we're going in? Any thoughts, on the content, where families should maybe access this booklet, or if there's anyone else we should be involving in this feedback loop that we are on right now? And kind of what the survey that we did, I'm happy to share the non-graphic designed version, if that's helpful for people, or if anyone is interested in giving very detailed feedback. Again, with the caveat that it's not the final version, and we should not be sharing it broadly. I'm not seeing anything in the chat. So this is reassuring. I do want to plug all of our resources if people aren't familiar with all of our content. We have things grouped by audience, so easier navigation. Our directory is in here that I've mentioned a couple times. If you have any thoughts after today, definitely feel free to reach out to me, or actually, Nini is out for this month, so if you want a quicker response, reach out to me or the general inbox. We also have a survey if you want to provide me some feedback, or any of our resources feedback. But yeah, thank you all for your time today. Is there anything else I can help people with, or any questions I can answer? I guess just to summarize some points that we've touched on, incorporating more on insurance, cost, navigating logistics, and reassurance with the family health history, parent to parent, calling that out specifically. And y'all are wonderful and record this, so I can also go back through if I miss something. I'm seeing something pop up in the chat. Oh, yep, there's my email. Thanks, Monica. Yep. Okay. Y'all have been too kind. I'm so over the time that I was allotted here. Here, I can stop sharing my screen here. Thank you, Leanne. Oh yeah, okay, back to the right screen.
Thank you for presenting, Maddie.
Yeah, thank you. It's wonderful to get all this feedback. I love feedback.
All right. Did we have any additional feedback? Okay.
And anything else in the chat?
All right. So the plan is to go into a 10-minute break, and then we'll have our optional networking session. And that is usually an hour long at the maximum. Again, it is optional, so if we want to take a little 10-minute break, I won't put my slide up just because it is inaccurate at this time. And then we can reconvene and we will go forward from there. So we'll make it a whole amount of time. So let's do 12 minutes. I'm liking the 12. So, we will see everybody back at 12:30. Wow, time flies when you're having fun. All right, I'll see everybody back in a little bit here.